All right. Well, thanks again for having me. I feel like a lot of this didactic portion, I've been on these PGx ECHO meetings before, and there's such amazing people, amazing speakers. And so I'm certain you probably won't learn much from me, but I'm happy to provide a review and just talk about pharmacogenomics in our geriatric patients, and then a review of a couple medications that will be pertinent to the cases today. I am a consultant for Orencia. So first of all, I'd like to share the third cause campaign. So adverse effects used to be the fourth leading cause of death in the United States. And then this year in March, it was announced that they have actually moved up to the third leading cause of death in the United States, according to the American Society of Pharmacovigilance. So this is a really big deal. Adverse drug events account for 250,000 deaths annually, surpassing both stroke and respiratory disease. So definitely a problem. And us pharmacists have a part of the solution, which I'm so excited about, which is pharmacogenomics. Oh, I thought I had one more slide here that showed, shoot, I don't know where that slide went. I wanted to show that part of this third cause campaign, they have bullet points for how we're going to overcome this third leading cause and how we are going to get away from so many adverse drug events. And one of their major bullet points for addressing adverse drug events is pharmacogenomics. And I was very excited that they listed that in their action plan to reduce adverse drug events. And so I think you can see it on the link below, but I love their action plan. I love that they included pharmacogenomics because there's a huge problem with adverse drug events, but pharmacogenomics is definitely part of the solution, which I love. So why are older adults more prone to side effects? Well, a number of reasons, right? That we all know as we age. We have age-related changes in body composition. Unfortunately, our muscle mass goes down and our body fat goes up. And so those are age-related changes that are hard to reverse. And when I think about my older adults in the nursing home, so many are sedentary. They have difficulty with mobility. And so maintaining that muscle mass is very difficult. We have changes in our liver function and our kidney function, which tend to decline, which, as you all know, changes how we metabolize and excrete medications. We become frail. So our older adults are so prone to falls. And all of you know that work with geriatric patients and work in nursing homes. Falls are always a problem. If people could solve the fall dilemma, they would be a millionaire, because those falls with injury and falls with fracture are what often land people in the nursing home. And so becoming frail and falling is a major problem for our older adults. Of course, comorbidities. So our older adults usually have more than one disease state. They might have diabetes. They might have a history of cardiovascular issues. They might have a respiratory disease. And so many of them are living older, but they're also living with multiple disease states, which can make it difficult to treat and also leads to the next problem, which is polypharmacy. Polypharmacy can, be defined different ways depending on who you're looking at. It used to be 5 or more medications. Now they're talking more like 10 or more medications. But either way, I would say a vast majority of my patients admitted to skilled nursing facilities are on at least 10 or more medications. It's rare that I see less than that in my nursing home admissions. And so with polypharmacy comes those drug interactions, those phenoconversions, and all those things that can cause medication-related adverse effects. And then inadequate testing of drugs in older adults. We know our clinical trials often exclude older adults, and so we don't have a lot of testing in our older adults. And I will also say that when it comes to pharmacogenomic studies, there's a lack of trials in older adults as well, especially in skilled nursing facilities. Oh, and here's the slide I thought I was missing. Here's the third cause national action plan. Look at that third bullet point. I put that kind of box around it, but advancing pharmacogenomics and precision medicine. So promoting policies that increase access to genetic testing and clinical decision support tools, reducing preventable adverse drug events by tailoring medications to individual patients. I love this. I include this in almost every presentation I give because I'm a huge advocate for pharmacogenomic testing, especially with my older, frail adults. And think of many who have cognitive impairment. They can't tell you if a medication's not working. They can maybe not tell you if they're having a side effect. So I especially love it in my patients who have cognitive impairment. So thanks to some help from the folks at PGx ECHO, we found a study on pharmacogenomics in community dwelling older adults. So what they did is they took 13,670 older adults, which they defined as 65 and older, that were enrolled in the Esprit trial, or the aspirin and reducing events in elderly trial. So they were invited to participate in a collection of specimens for medical and genetic research. And those that opted in had a 10 pharmacogene panel tested. And so they looked at a few different things. They looked at prevalence of actionable PGx genotypes, which they defined as linked to a guideline that recommends a change to standard prescribing. They looked at use of cautionary medications, which they defined as associated with an actionable PGx genotype. They looked at polypharmacy, which they defined as 5 or more medications. And they also looked at cytochrome P450 enzyme inhibitor and inducer use. So what they found in this study was that 98.8% of the participants carried at least one actionable pharmacogenomic genotype, but on average, there was 3 per patient. The 2 most frequently observed genes with actionable genotypes was the VKORC1, which accounted for 61.1%, and CYP2C19, which was 59.6%. 27.5% of participants were taking at least one medication for which a PGx guideline recommended a deviation from standard prescribing, so about a fourth of them. And then statins, NSAIDs, and PPIs were the most used cautionary medications, which NSAIDs in older adults are not great to use anyways. So it's kind of a problem that they were one of the top 3 most cautionary medications used. So it is important to look at these pharmacogenomic labs and see how they're metabolizing their medications. 83.9% of participants reported taking a polypharmacy regimen, which, like I say earlier, is not surprising to me based on my nursing home admissions. 68.2% reported use of at least one cytochrome P450 enzyme inhibitor or inducer, so many drug interactions in this population. So that's a little bit about this study. I want to talk about 2 different medications that will be relevant to the cases today. One's atorvastatin and one is tramadol. So the first case will deal with statins, and the second case that we present today will deal with pain in older adults. So 1 in 4 Americans age 40 and older use a statin. That I was actually kind of surprised by that number. And I will say that I haven't looked at the data, but I will say the most commonly prescribed statin that I see in my nursing home patients is definitely atorvastatin, probably with Rosuva and Symba shortly behind that. But atorvastatin seems to be widely prescribed for our older adults. So the SLCO1B1 facilitates the hepatic uptake of statins. And so decreased function of the SLCO1B1 can increase systemic exposure to statins. And so we all know statins are classified as high, medium, or low intensity based on their LDL cholesterol lowering ability. And figure 1 in the CPIC guidelines provides statin recommendations that are stratified by the SLCO1B1 phenotype, which is really nice. And they're to be used in conjunction with the American College of Cardiology and the American Heart Association guidelines. And you'll see, I'll show you in a couple slides these figures, but when you look at the figures, the light gray boxes have the lowest risk for statin-associated musculoskeletal symptoms, or SAMs. The dark gray boxes, we're supposed to use those with caution because there is a possible increased risk for SAMs. And then the black boxes in these figures, we should avoid because evidence suggests an increased risk of harm with use of these statins in patients. As far as general guidance for patients that are already taking a statin when looking at these figures, if they have a moderate SAMs risk and the patient has been stable at least 4 weeks with no symptoms suggestive of SAMs, it's reasonable to continue that statin medication at that dose. If it's been less than 4 weeks, they say to consider changing to a lower SAMs risk statin medication and dose to prevent the development of SAMs. And then it's a little bit different for high SAMs risk. So if they're a high SAMs risk and they've been stable at least 1 year, so they use 1 year instead of 4 weeks, with no negative effects, it would be deemed safe to continue that statin and dose long term. But if it's been less than a year, they say to consider changing to a lower SAMs risk statin and dose to prevent the development of SAMs. And so this guidance was based on expert opinion and the onset of SAMs observed, and it was for a simvastatin in different SLCO1B1 genotypes in a single prospective clinical trial. So take it with a grain of salt, but it is nice to have that guidance, because oftentimes when we get our PGx reports back for patients, they have already been taking statins for quite some time. So it's nice to have this guidance if you're not sure what to do. So here are these figures from the CPIC guidelines. The first one here is for SLCO1B1 decreased function. And again, it breaks it down by intensity of statin and then risk for SAMs. So you'll see the high intensity statin, the lowest risk for with decreased function would be Rosuva 20, and then moderate would be atorvastatin 40, rosuvastatin 40, and then high SAMs risk is atorvastatin 80. But it is nice that they do this for you, break it down by intensity and SLCO1B1 function. And then here is poor function SLCO1B1. So a high intensity statin, the low SAMs risk would be rosuvastatin 20, high SAMs risk with atorva 40 to 80 milligram and rosuva 40 milligram. So that's a brief overview of atorvastatin. And now we'll talk about tramadol, because our second case today will deal with pain management in older adults. And so this is so commonly known. I'm sure this will be a review, but nonetheless, it's good to have a review sometimes. So there's substantial evidence linking CYP2D6 genotype to variability in tramadol efficacy and toxicity. Our CYP2D6 poor metabolizers have lower plasma concentrations of the O-desmethyltramadol, or the tramadol active metabolite, versus normal metabolizers. And so CYP2D6 poor metabolizers fail to exhibit pain relief or analgesia in response to tramadol. Ultra-rapid metabolizers have a higher Cmax of the O-desmethyltramadol versus normal metabolizer. And then the ultra-rapid metabolizers also have greater analgesia, but also higher incidence of nausea compared to normal metabolizers. And so here's the CPIC guideline chart on tramadol. And so our patient today will have CYP2D6 is a poor metabolizer, and you'll see the recommendation from CPIC says avoid tramadol use because of possibility of diminished analgesia. If opioid is warranted, consider a non-codeine opioid. And the classification there is for strong evidence.